Greetings, my name is Natalie Gill-Mensah, and I am one of the Borgen Project's board members, here to share a few words with you on the importance of global health equity during the COVID-19 pandemic and beyond. The COVID-19 pandemic has exposed the magnitude of global health inequities, particularly in the United States. The World Health Organization defines it as avoidable, unfair, or remediable differences in health. It has also called out structural racism in institutions, practices, and policies that allocate resources differently based on access and proximity to power and money. COVID-19 mortality rates are more than twice as high in Black, Latinx, and Indigenous populations as in white populations, and there is also correlations found between socioeconomic status in the United States and COVID-19 mortality rates. You may ask why I'm talking about racism and domestic social determinants of health at a global health event. It's because they are very much related. Equitable access to health service is a global pandemic that is rooted right here in the United States. It's not an either or. We have to care about and advocate for both and. The WHO notes COVID-19 has exposed persistent inequalities by income, age, race, sex, and geographic location. Despite recent global health gains across the world, people continue to face complex, interconnected threats to their health and well-being rooted in social, economic, political, and environmental determinants of health. Take a case study from Brazil from the Equity Health Journal. Author Peter Hangoma finds in his research that racial inequality is also an issue in Brazil, as the majority of poor people are Black. Again, the higher case fatality rate by COVID-19 is among Blacks in Brazil. Although Brazil Blacks represent 23.1% of hospitalized Brazilians, with COVID-19, 32% of them died, and among whites, the situation is reversed as the proportion of hospitalized cases is 73.9%, and 64.5% died. We can also look at the African continent that has not yet got COVID-19 under control. In Namibia, right at this moment, there's a COVID-19 crisis with a huge spike in COVID-19 cases, not enough ICU beds. Even though, like many African countries, the Namibian government put preventative measures in place, the ability to follow them across diverse socioeconomic settings varies. Namibia is one of the fortunate countries in Africa with over 75% of urban households having access to sanitation, but rural households only have 28% access. Here where I sit in Ethiopia right now, less than 25% have access to improved sanitation. The COVID-19 pandemic has revealed significant gaps in country health information systems, while high resource settings have faced challenges related to overstretched capacity and fragmentation. Weaker health systems risk jeopardizing hard-won health development gains made in recent decades. In some countries, health offices, departments that previously treated tuberculosis had to shift to focus on COVID-19 patients, which led to some TB patients not being able to access the care they need. Investing in strong health information systems is vital to ensure disaggregated data reaches decision makers and achieve equitable health outcomes. Data impacts policy, and if data is unavailable or inaccurate, any health commodities, supplies, vaccines, or treatments are not channeled to the places that need it the most. One of our current challenges is as variants continue to mutate and numbers still grow, there is a significant decline in preventative behaviors such as physical distancing, mask wearing, and hand washing as households overcrowded increases. The ability to follow prevention behaviors, particularly overcrowding, can be very difficult, if not impossible, for low-income communities around the world. Louise Ivers and David Walton of Harvard Medical School in Boston remind us that diagnostics, pharmaceutical interventions, and public health solutions for other pandemic diseases such as tuberculosis, HIV infection, and cholera have never fully trickled down to marginalized or impoverished communities. That's why, for example, HIV infection rates remain alarmingly high among adolescent girls in South Africa and transgender people in communities of color in the United States. And why tuberculosis still remains a major public health concern despite the advent of effective therapy for drug-sensitive disease almost 50 years ago. We have an opportunity now with COVID-19 to change that story. You may be asking yourself, how can I help? Often, widespread access to life-saving therapeutics like treatment for HIV infection and now the COVID vaccine has been made possible for marginalized groups through hard-fought activism and advocacy. We can pause to celebrate the Biden-Harris administration's recent commitment earlier in June to share 80 million doses of our vaccine supply with the world. I'm not sure how much of that will make it to Ethiopia's 117 million people, but it's a start. We can't stop the pressure now. Work with us at the Borgen Project to get the word out of the importance of investing in and supporting policies that protect the most vulnerable of us around the world. Each one of you are an important part to improving health equity for all of us. Thank you so much for your time.